My friends, why don't we get started a little bit? And as people finish up their meals, they may come up and join me. So for now, you have a faculty of one. But again, remember, the most important thing is leave this conference with knowledge. Leave this conference with information and confidence that you understand your disease better. But most importantly, leave this conference and get the word out. Okay, so make sure everyone knows. We got to do this. All right, excellent. I appreciate it, Dr. Parker. So we have Dr. Ryan and Dr. Parker. Let me see if I can find some interesting questions that they can answer.
I better leave right now.
Oh, might be interesting for Dr. Ryan. What is the best way to explain what neuroendocrine cancer is to others in simple terms? People look at me with that deer in the headlights look. I just don't know how to simply state my cancer.
That's that. Yeah, so my first two slides, I tried to summarize that as best I could, but it's challenging. I think it is, it's challenging. So I'm not sure that I have a very simple explanation of it, because I think that I think it's a tumor that was named based on historical errors.
Yeah,
frankly.
that's for sure. The easiest way to say it is you can say, I have the same cancer that Steve Jobs has. Right? That's just kind of the easy way to do it, except mine is of the lung. That's kind of just the easy way to do it. And then people say, oh, and then the conversation stops.
And then suddenly you're talking about Apple.
That's right. And then you're talking about your iPads and stuff like that. But the easiest way to kind of describe it is say, I have like maybe a hormone-producing cancer. I mean, something like that. Just throw a couple of hard words out there, and they'll just stop. Yeah, that's it. But the most important thing is you can say, but it's very slow growing. I'm staying on top of it, and it can be a chronic disease. In fact, Dr. Oberg and I we saw a whole bunch of you guys this week. And the conversation was always, you can live for a long time, and as long as you take care of it, it's the most important thing. Okay, actually, this is good for the whole group and for Dr. Ryan too. Does the Ki-67 value change significantly in different areas of the tumor?
So it can be variable, and when we do this, we use computers. We use a computer to help us with the Ki-67, and we circle a number of different areas in the tumor. So we don't just circle one area. We go to a variety of different places within the tumor, and it may vary a little bit, but overall that's how we get an average of what the Ki-67 is within the tumor.
How about fine needle aspirate or fine needle biopsy? Does Ki-67 really work?
I wouldn't think that it would be great on a cell block just because of the way that those are processed. I would think, and that fine needle aspiration is what we make a cell block out of. I have not personally used a Ki-67 on a cell block. I think you'd want a tissue block, but I don't have experience with that.
Yeah, actually, I totally agree. I think the fine needle aspirates are too insensitive. It's good enough to make the diagnosis, but when people start putting too much information on it, I think it can throw you off a little bit. What do you think, Dr. Oberg? FNA.
Actually, I totally agree with what's been said. We are not looking at fine needle aspiration and say that you can count Ki-67 or mitotic count or so. So we need a tree-cut biopsy at least.
Is there cryo available for lung? Like cryoablation, Dr. Parker, do you know? I've never done it before.
I have not seen it reported. I'm not aware that it is. There are various technologies you're looking at, but cryo has not been one of them that I've seen listed or utilized that I'm aware of.
Yeah, not that I know of, but if anyone does it, let me know. Okay, when do you decide to do an MRI? Does something need to show up for some CT scan? The answer is sometimes yes, because your insurance company won't let me order an MRI until you have a CT scan. So they'd rather spend the money on the CT first before the MRI. In my personal practice, as Dr. Ganush had kind of mentioned before, is that I use the MRI very intensely because I want to look at the liver. It's just much more sensitive for lesions in the liver. And so pretty much everyone, CT positive or no, they get an MRI with me, especially when I have a strong suspicion for something inside the liver. Do you use a lot of MRI, Dr. Oberg, in Sweden?
Yeah, we do, but sometimes there are problems to get it because there is a waiting list to get the investigation. So I think we do as much CT scans as MRIs at the moment.
Eric, I'll speak up from a thoracic surgical standpoint. The MRI is not as sensitive as a CT for when we're looking at the vascular structures,
of the chest.
Of the chest. It's that. And so in general, in chest pathology, a CT scan gives us much better picture. For one thing, the MRI is not as fast. So you've got all the blurring of the motion of the heart and of the great vessels. And so it almost turns into a blurrogram unless you get a gated scan, and even those are not really as great. So the neurosurgeons, the GI surgeons, the orthopedists love MRIs. As a thoracic surgeon, we rarely get it other than if we're looking for a particular thing, like you and I were talking about, trying to determine in a bronchus, is there invasion or is this just a mucosal lesion? That might be able to help us, but it's in a specialty area.
Right, agreed. Oh, this is good. How important is it to have the same pathologist?
It is not that important to have the same pathologist as long as you have as long as the pathologists that are looking at it are aware of the diagnosis. So there are criteria for making the diagnoses that I went through, and those are not like only a secret subset of pathologists have those at their disposal. So we all have the same books, hopefully, and we all use the same references. So as long as it's a pathologist that's using the appropriate tools, they should be able to make the diagnosis.
This is interesting. Do women survive longer? Dr. Oberg, you know?
I must say that there is no evidence-based medicine showing that women are living longer with the neuroendocrine tumors. I have not seen any data presented so far. Nothing else.
No, not that I know of. I think the one thing that's been shown is that people who are well cared for at specialty centers do live longer. There's improved survival compared, just the general population in the U.S., say, compared to Uppsala. There's definitely a difference there. This is actually interesting. Is there a greater risk of spreading when having surgery? Like when you open up and the oxygen gets in and things like that. Have you heard that, Dr. Parker?
That was, bear the term, the old wives' tale. If you go back to the time of our parents, you all knew there was Uncle Louie and Aunt Minnie, who somebody had a surgery and it went wild. You opened it the air. On the other hand, think about it. In those days, there were no CT scans, there were no MRIs, and so truly people did have exploratory surgery. Fast forward today, we don't have exploratory surgeries except in very, very rare occasions, because you can tell, is there widespread metastasis? If you need to know something, a CAT scan will give you anatomy. You get your specialty scans that will tell us the physiology. We can put a needle, or the radiologist can put a needle in. So what used to be, if they opened it up and went wild, it was usually that it was widely metastatic at the time they had their exploratory surgery. So there is not anything that says having surgery accelerates it. You have to look at where did those terms come from, historically what went on, and why are we seeing things differently. And technology really has made a difference today, and hopefully we can put some of those into what now call them old grandma's tales.
Right. I totally agree. So, so who gets who gets carcinoid heart disease, and who gets carcinoid heart problems, Dr. Oberg, and then how do we fix it, Dr. Parker?
No, actually, we have seen that there is a correlation between high levels of circulating serotonin and the development of heart disease. But that is not always true, because sometimes we see a carcinoid heart disease develop within 10 days after, for example, embolization. And so most people think that serotonin is the main mediator of the carcinoid heart disease. And I think it's very important to keep the levels as low as possible.
How do we fix it? How do you and I fix it?
Yes. The things we've learned together. The thing to realize on the carcinoid heart disease, it primarily happens on the right side of the heart, meaning the tricuspid valve and occasionally the pulmonic valve. Those valve leaflets are very thin. They're thin enough, fine little leaflets that you can see light through. And they're leaflets that come together and they're held by little chordae down to the papillary muscles, so it's like little parachute wings that open and close. Something about the byproducts and metabolites from carcinoid that causes the actual leaflets and the chordae to shrivel in until you end up folding in and you get these little nubbins that just are moving back and forth instead of a nice leaflet. So you lose coaptation, you lose the actual tissue of the valves coming together. So it is not a valve that can be repaired, and so it needs to be replaced. So what you need to do is go in and have basically open heart surgery, or you go in and explore the valve, and actually you oftentimes don't even remove it. You may take a little biopsy of it, but usually you want to leave that fibrous nubbin there to anchor the new valve on, and we put a new tissue valve on top of it. At the present time, for the tricuspid valve, it has to be an open procedure. For the pulmonic valve, there are some catheter-based procedures that may be able to replace a pulmonic valve. Part of the problem with the tricuspid valve is right adjacent, or right at the very base of it, is the conduction mechanism. So there's about a 10% chance that in putting in that valve, you could end up actually injuring the conduction mechanism and the patient ends up needing a pacemaker. We've here done them through a minimal access right thoracotomy, small right incision, a little incision in the groin where we attach them to the heart-lung machine. And through the small incision, we can isolate the heart, isolate the right atrium, keep the heart warm and beating, and actually just open up that chamber and sew in a new valve and close it back up. So by doing that, it's been a much less of an insult to the patient than the old way of putting them on, splitting the sternum, stopping the heart, and replacing it.
That sounds like a dangerous operation. Anyone survive that operation?
Thank God they do. Actually, the mortality on it has been really very low, down in the neighborhood of 1 or 2%. Most of the time, the people are in the hospital depending upon their underlying condition. If we're catching them early, where they haven't deteriorated, we would like to get them out of the hospital in 4 or 5 days. Obviously, if they've got lots of congestive failure, lots of fluid retention, it can be a longer procedure and a longer recovery.
Yeah, but I would say it's actually much more life-threatening to have a persistently broken heart valve than the operation. I mean, it's actually the disease is worse than the repair. And so I always like it when I see someone who's had a nice repair and is like eating lunch with us. All right, does Afinitor replace Sandostatin? Can both be given together? And what are the indications for starting Afinitor? I think Dr. Ober will mention this in his lecture, but maybe you can just touch on it now.
Yeah, I can just comment on it just now, but I will show you the algorithm for how they see treatment for this type of tumors. But usually we start in most patients with somatostatin analogs, and that can be kept for basic treatment for very long periods of time. But when we see some progression of the disease, we can consider adding Afinitor on top of the current somatostatin analogs. And I think in most centers today, we combine somatostatin analogs and everolimus or Afinitor. So, but I'm coming back to that in my presentation.
Okay, Bert, we'll talk about it. If your Artria scan is always negative, can the gallium-68 still be done? Let me answer that. So, essentially, gallium-68 is the next generation of Artria scan. So the Artria scan, basically, the camera and the film aren't as good, and the gallium scan, the camera and the film are much, much better. So it's like going from a black and white little TV to a high-def TV. I mean, it's kind of how it is. So sure, can you make stuff out? Yeah, maybe. Did you make it all the details, with your low-def TV? Probably not. So the answer is yes. Gallium scan can show stuff that isn't on the Artria scan, which is very important. Should everyone with carcinoid be on somatostatin analog? Dr. Oberg?
I mean, that is a good question, because if you have a non-functioning tumor with not so many symptoms, maybe nothing at all, and you have a stable disease, you have a possibility of watch and wait until you see progression. But as so long as you have symptoms related to the carcinoid, I think you should start with somatostatin.
How do you make the diagnosis of dip neck in patients who have signs and symptoms, but maybe nothing on CT? Do you bronch them? Do you get labs? Do you clinical diagnosis? Or is it just a diagnosis exclusion? So let me just come on that real quick. So I think dip neck is more a radiologic and pathologic diagnosis, but there's no question that you could have these teeny tiny little tumorlets inside there that are invisible to CT scan. And so either you have to go in there and get a chunk of tissue to make a diagnosis, or you're just trying to treat it symptomatically. I don't think anyone would venture to go and do a thoracoscopy to just get a piece just because we think it might be. So I think most of the time we just kind of treat it, but without a radiologic diagnosis, we don't usually call it dip neck. Anyone agree? Everyone do that? Okay, so I heard that Ki-67 tests. By the way, you guys should know the Ki-67 was pioneered by Dr. Oberg. When he first started doing Ki-67, I think people thought it was a waste of time.
They didn't believe in it, so it took me about 8 years in Europe, but it took 25 years in US.
This is just interesting. So I heard, this is how the question starts. So I heard that the Ki-67 tests show doing well. So I assume that's low Ki-67. And then things go south. Could the possibility of using quote unquote Mary Jane, in America we call that marijuana, Dr. Oberg. In Colorado we call it a tax boon, is what we call it. Is there any evidence that marijuana can slow the growth of the tumor? How about that? I can't answer that question.
You should answer, because I have no experience.
Yeah, I know. That's right. That's right. So who? Yeah. So I don't really know the answer to that question. I think people have talked about it, the cannabis oils and the smoking, but I personally have not seen anyone take with neuroendocrine have an improvement as like shrinkage of tumors. They're usually on something else, and the way I usually use it is mostly for symptom control. So if someone's very nauseated, or someone's having weight problems, or someone's having kind of chronic pain, they seem to. I would much rather give a kind of a marijuana-based therapy than a whole bunch of opioids, because opioids have been demonstrated to actually significantly shorten people's lives. So okay. Do patients with liver mets show abnormal blood work? Is liver MRI recommended for all patients, or just until you become symptomatic? I'll answer that. You can have liver mets and have completely normal blood work, because if anyone's ever seen me and I will order a whole bunch of bloods for you, the reason is because I want to find out which marker works for you. There are definitely people who have lots of carcinoid neuroendocrine tumors who have totally normal chromogranin or totally normal 5-HIA. And so you'll see a doc who'll say, oh, you can't have neuroendocrine because you have a normal 5-HIA. And in fact, your liver has like 10 tumors in it. So it's unfortunately, it's a kind of a hit or miss thing. So that's why I do that. And the answer to the question is, I always get a liver MRI for the same reason, symptomatic or no, because I want to know the tumors. And I really what I want to know is what's the opportunity to remove the tumors as much as possible, because I feel very strongly that if you can remove tumors, then you can actually improve the person's kind of overall status. Because one of the things that can get people is the erosion, the loss of liver. So if I can turn the clock back, I always try to do that. When it comes to mediastinal lymph node dissections, is this removal of all mediastinal nodes? Is there such a thing as chest lymphedema? We talked about that a little bit.
Number one, you can't remove all the nodes because you can't see all the nodes. Besides, there are a number of other very vital structures in the mediastinum that you must leave behind. Things like heart, trachea, esophagus, thoracic duct, etc. So the idea of mediastinal node dissection, it really is a sampling. There's been lots of discussion and ongoing discussion about how thorough discussion or how thorough you need to be. And by the same token, in carcinoids particularly, if you have a node that is under 2 centimeters and is not active on PET, the chances of it being pathologic is really rather low. And so it's probably more important the number of stages or the number of stations rather than the number of nodes. This is one of the things that will be on my slides is there's a controversy because in colon cancer it came out with big studies that you had to see more than 10 lymph nodes to have meaningful staging. So people are trying to apply that to the chest. And there are times when Maggie knows, I laugh about it, I said, I can only find 5 nodes. Can I cut them in half so we can get 10 nodes? But when you try and get goal-oriented people to meet a certain mark, is it really meaningful or are they meeting a mark? And so the reality is you need to make certain you're hitting the appropriate stations. And we'll kind of talk about that in the next talk.
Yeah, that's good. Actually, a lot of these questions, unfortunately, are going to be addressed in the next few talks, so I'm going to skip over them. So forgive me if you gave me one of these things and we didn't talk about it. But one is, I think, is interesting, and we should just kind of clarify. Is there evidence that lung nets are hereditary? Dr. Oberg?
Yeah, there are some lung nets that are inherited forms, and that those related to multiple endocrine type 1. So if you have a patient or a family with NN1, you must always check for finding or lung nets. Otherwise, there is no evidence that it's an inherited form of neuroendocrine tumor.
Right, so in the majority of cases, I think the vast majority, it's kind of a lightning strikes type of thing. But when someone has the usual kind of constellation of pituitary, pancreas, parathyroid kind of constellation, then you have to really think about it. But I've had families in which, there's an MEN family in which 1 out of the 4 of them have lung and then the other 3 don't, and so it just depends. What are the typical blood markers for lung neuroendocrine? Dr. Oberg?
I mean, standard is chromogranin A. I think that should be tested at least once in all patients. And then we have the possibility if the patient presents some symptoms to have a specific marker. Serotonin for carcinoid syndrome, histamine for atypical carcinoid syndrome, those with very severe flushing with swelling of the lips and so on. And then we have for the Cushing's disease, of course, ACTH and cortisol. Otherwise, another marker that I strongly recommend, particularly for atypical lung carcinoid, is NSE, neuron-specific emolase. That is an enzyme that is secreted by the tumor cells. And it's rather stable in the circulation, and you can follow it over time. So if that is positive, it might be even a better marker than chromogranin A or pancreas cancer.
Interesting. Let me ask one more quick question. Is there a relationship between neuroendocrine and autoimmune disease and pregnancy? Any experience with that?
No.
Yeah, the only thing I'll comment on that is I have seen, especially in the lungs, and this is more anecdotal, is that a lot of people will complain of saying, yeah, I have lung neuroendocrine, but I also have thyroiditis, or I have some other kind of soft neuroendocrine, some soft autoimmune. There have been no studies to link the two, but there seems to be a correlation. And it may just be that autoimmunity is a little bit more prevalent in women anyway, so they may just kind of strike at the same time.
I can just comment on that because you have sometimes paraneoplastic syndrome.
Oh, sorry, yeah, that's yeah.
So they can also be of autoimmune type, but they are very rare.
Yeah, they have to be.